Specialty Stories, session number 10. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field, give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to the Specialty Stories podcast. I'm your host, Dr. Ryan Gray. If this is your first time here, thank you for joining me. If you don't listen to any of the other podcasts we publish, go check them out at mededmedia.com. That's MEDED media.com. Today I have a great episode with primary care and a physician who is in a solo private practice practicing family medicine. Let's go ahead and jump right in.
My name is Dr. Sasha No, and I practice family medicine.
And you are in a private practice setting, correct?
That's correct. I actually am in a solo practice, which I started straight out of residency.
Talk about that decision for a minute. The decision between family medicine in an academic center, in a community setting, or starting your own private practice.
Well, as far as what the decision entailed for me, I think really it has to be about where you find your happy place to be. And for me, I knew that the hospital setting was not exactly my happy place. I enjoyed academia. I spent many years in academia previously. This is my third career, and we can talk about that some more. But I did know that my happy place would be in an outpatient setting primarily. Even though I have seen my patients in the hospital, the outpatient setting for me was where I really felt like I wanted to spend the majority of my time. And in terms of determining whether I wanted to do that as an employed physician or as a solo, my own practice, which I owned, we had a couple of factors that went into that. I really wanted to own my own time. As I mentioned a minute ago, this is my third career. I have a family, and I was older when I started medical school. So it really meant that I had a bit clearer vision for how I wanted my time to be. And so when I went into residency, I really focused on learning a lot about what it would take to start a practice and run a practice, because I wanted to be able to determine my work hours and my workload, and just have some flexibility there.
How long have you been practicing now?
Just over 5 years out of residency.
When did you know that family medicine was what you wanted to practice?
In my fourth year of medical school, actually. Interestingly enough, I went to medical school to become an emergency medicine physician. I had shadowed in an ER for the year prior to medical school while I was still in an academic position. And I loved the ER. I loved being able to take care of patients, that came in and, that high acuity and just the ability to feel like, I'm really doing something here and helping patients. And so when I went into medical school, I thought, ER medicine is what I wanted to do. And that is what my focus was. When I got to my fourth year of medical school, I actually had an opportunity to do ER rotations where I was following, that schedule where you change shifts, you have a daytime shift today and a nighttime shift tomorrow, or, this back and forth of sometimes working during the day, sometimes working overnight. And I really discovered that I actually am a work in the day, sleep at night kind of a person.
A normal person, you mean?
So, for me, that really is what made the decision for me. I actually remember telling my husband, I said, I think I'm too old to do ER medicine. I don't do this whole shifting of my sleep patterns too well. I was in my 30s and I thought, man, maybe I'm too old to do the shift, the shift work. But really what it ended up turning out to be is just, I am happier when I work during the day and sleep at night. So family medicine for me was the absolute next best thing, because I can essentially have as much, deal with as much acuity as I wanted to, and take care of patients on a continual basis. The part about ER medicine that you knew I was going to miss was the continuity of care, and family medicine really fills that gap for me in a way that's very fulfilling. So it turned out to be the best decision in the long run. Initially, it was a choice of, necessity for sleep patterns, but it's really been the best thing I could have ever done.
You mentioned the acuity of care. Can you just define that for somebody who doesn't know what that means?
Patients, if they have medical conditions that are life-threatening or very, very serious, requiring hospitalization, indicates that they're, a higher acuity patient. A lower acuity patient is someone who, doesn't require, hospitalization or, going to an emergency room or anything like that. It's things that can be handled as an outpatient in office.
What traits do you think lead to being a good family medicine physician?
I think the most important thing, or the most important trait, is really having a sense of deep compassion and caring for someone as a whole. And it's not to say that other specialties don't require compassion, deep compassion. I think naturally as family medicine physicians, we attend to the entire patient, and I'm an osteopathic physician. So the whole, mind, body, spirit approach is very important, but we really also encompass a lot of what's going on, not just with that person, but with their dynamic that's going on in their lives, be it with other family members. And so I think a level of really a desire to want to help someone beyond just a particular set of medical problems or symptoms, if you will. You really have to desire to want to have a follow-up and this continuity of care that, at a different level. It's really about relationships. Really anything we do is about relationships. But I think more so with primary care, you're really building deep relationships with your patients. And that can be very impactful to them. So I think you really have to desire those types of relationships. And that, I think, is probably hugely important. I also think that you need to desire to know a lot about a lot because family medicine, takes care of the, all body systems. So if you want to know a lot about a lot, I think it's a great field for you. I think it can be overwhelming for some people because it really requires, knowledge about multiple systems, the depth of which, depends on the individual. But I think not being afraid of complexity of multi-organ systems, if you will, because you're going to be faced with it. You don't just, deal with one body system. Not to say that that's not complex in and of itself, but understanding to a level of how it all plays together and what you really need to address and what needs to go to a specialist is huge. So I do think it requires a broad depth of knowledge, and you've got to like that.
What types of patients are you seeing, or is a family medicine physician seeing in a typical day?
So, of course, with it being primary care, we do see a lot of chronic illnesses, things that from a cardiac standpoint or a pulmonary standpoint, your hypertension, your heart failures, your COPD patients, your chronic kidney disease patients. A lot of the patients that I see, because a pretty significant population of my patients are older, they are really pretty complicated in terms of having, diabetes with heart failure and or COPD. You know what I'm saying with chronic kidney disease? Like I have a lot of patients that are 65 and over. So they're pretty complicated. That's a lot of my day is those types of patients. I really enjoy geriatrics. So because of that, a lot of my day is taken up with seeing these individuals who really have multi-organ system, medical conditions. And then probably the rest of that is really on an urgent care sort of a basis, not just your, coughs and your colds, but we'll see, your typical, like rashes or cuts or bird attacks or chest pains or whatever. We do get a smattering. I do a lot of surgeries in the office in terms of dermatology surgeries. And so, we'll do that because I've really, enjoyed procedure-driven environment in the past. I really do a lot for my patients from an urgent care standpoint. So it's a combination really of your routine chronic medical condition patients in addition to whatever urgent situations come through the door. And we get quite the variety of those.
Describe a typical day in the life of a family medicine doc, maybe not specifically for yourself, but in general, what a family medicine doc day would look like.
So really, as you look at your patients that you have for the day, you're really looking at, you're going to spend time before your patients come in, just really looking at who's coming in and why are they coming in and what issues do we need to address today, what preventative type things do we need to do for this patient, what things do we need to have close follow-up on. So there's the preparing for your patients, there is, seeing your patients, and then there's documenting on everything that, happens, which I don't think is unique to family medicine, but a lot of what we get into as well, it's a lot of, we do face a fair amount of social issues in family medicine, which was something that, was a little bit more surprising to me for family medicine when I started, realizing that in my training. But a typical day really involves preparing for your patients when they come in, taking that time to think about really what all of their needs are that you might need to address while they're here, and just ensuring that they have proper follow-up for, coming back and making sure that their chronic needs are being taken care of. And so, you're seeing patients and then you are documenting as you go, really. And in addition to that, there's a lot of paperwork that comes around my desk for, coordinating care, really, whether it's referrals to have procedures done or referrals to specialists or calls to specialists to coordinate care. That was another thing that we do quite a bit of, as well as just doing that quarterbacking of care for the patient. So if I needed to speak to a patient that I'm sending to a cardiologist, and I talk to that specialist to let them know what's coming down the pike for that patient, and that's something that I do. So it's a combination of all those things.
Do you have to take a lot of call? I know for you in private practice, it might be a little different, so maybe a little more general.
Because I'm a solo physician of the practice that I'm at, I take call all the time. I'm on call 24/7, and you might think, oh my gosh, that's crazy. Like, don't you ever sleep? And but actually, it's not. It's I will go weeks without a call after hours, and then I'll have a weekend. Well, I'll get 6 calls. I don't really get I think because I set a lot of expectations for my patients when I see them in the office and when they establish with me. We make sure that we take care of everything as much as we can during regular office hours. And they know for for emergent care, they can absolutely call me after hours anytime. And I can help them if I can. Otherwise, I'll refer them to an urgent care or an ER. But for the most part, a lot of the patients are, I've had for quite some time. So they're well managed in the beginning. There was a lot more call, I think, because patients were new and, I hadn't quite gotten them all stabilized to where, they were a well-oiled machine, if you will. So I took a lot more call in the beginning. And then, really as the years have gone by, I've really seen the call being, very, very manageable. literally weeks will go by and I don't get a call after hours.
Do you think you have good work-life balance?
So I think that ebbs and flows for me. As a mom, as a wife, as a business owner, as an entrepreneur, always doing other things, that really ebbs and flows for me. There are seasons where I feel like I'm doing pretty good at it, and there are seasons that I feel like, oh my gosh, this is horrible. When I started my practice, obviously that was a very intense time for us, and I put a ton of hours in. Probably 14 to 17 hours, initially a day for a good year. But I knew what I was building, so we made the sacrifice to do that. However, right now, and for the last 3 to 3.5 years, really, I do feel like I've achieved a lot better in terms of work-life balance. I'm usually gone. Today was a late day for me. I'm usually done seeing patients between 3:30 to 4. And then I get to go home because I structure my administrative work in a way that allows me to get a fair amount of it done while I'm here. And if there's anything left, I'll do it after my kids go to bed or I get up. I'm an early riser, so I get up early. So I do really get an opportunity to spend a lot of great quality time with my family most of the time. It's not 100%, like today. It's a later day in the office, even if I wasn't going to be doing this podcast. There are things that happen in medicine that you can't prevent. But for the most part, I feel like I get to spend a ton of time with my family. It just feels at times, I think, as a mom, that can be a little bit challenging because you always want to do more.
What does residency look like for family medicine?
So, it's a 3-year residency. I think the first year is probably the most difficult. And the first 6 months is even, the most intensive part of the entire 3 years. I think it takes about 6 months for, a resident to really get in the groove of being a physician and being the one making the call for patient care. But after that first year in family medicine, after your intern year in family medicine, to me, it really became more routine because I don't know, maybe it's a confidence level thing. Like you weren't as stressed out. You had a little bit of experience under your belt. If you wanted to do, more outpatient rotations, you can. I actually did as much inpatient as I possibly could because I knew I wasn't going to be spending a lot of time inpatient. And I wanted to make sure that I had as many of those skills to be able to manage my patients as an outpatient, if that makes any sense. I don't know if that makes any sense to you, but I just knew all the things that I wasn't going to get to spend a lot of time with once I got out of residency. I try to make sure I focused my time on those things while I was in residency. So I think the first year is intense. The first 6 months, very intense. But the last 2 years are, more manageable. And I think there is a light at the end of the tunnel, I think, after residency. If you choose to go into your own practice, then I think, you'll have some intense work for a couple of years. But after that, things settle down, so it's not this crazy, intensive, constantly stressed life that you experience as a medical student or as a first-year resident.
What should a student be doing to be a competitive applicant for family medicine residency?
Well, I think, family medicine residencies aren't, they're not very competitive, only because, there's a lot of them. Many of the slots really go unfilled, which is sad because it's really an amazing field. However, I think, we are seeing a shift in terms of a focus for the need for primary care. We have been seeing that for years. So really they're able to really look for the cream of the crop. And I do think it's a combination of competency and just really affability, really. You have to be competent and likable, able to work with other people. So everyone will say, well, you need to have great rotations, good, what are they called? Audition rotations. With the place that you want to attend. I would really recommend that if you want to be the most competitive for a slot in family medicine but really for family medicine, it was very helpful to have an audition rotation. And that's recommended for any medical student. If you know where you want to go, you need to do an audition rotation there. You need to get in there. Because they need to see you, they need to work with you, they need to learn what kind of person you are. It's unlike, obviously the board scores, if that's kind of like the first cut, right? What are the scores? That's step one. But really it's about who you are as a person, how well you work, how hard you're willing to work. And that's best demonstrated when you do an audition rotation. So I think to be the most competitive, that's something that, students should really be doing.
You're a DO. Do you see, or have you seen or felt personally any bias towards DOs in family medicine?
I can tell you what I find are patients that come looking for me as a DO because they've had experiences with DOs before. They're looking for someone who they perceive as having a different approach to patient care. And so if they've had that experience with a DO before, they come looking for me. Then I have patients that come and have no clue that I'm a DO. So, they're just looking for a physician and then they find out kind of along the way. So I don't know if that answers your question about, can you repeat that again? Let me see What
about from a residency maybe perspective? So as a DO student applying for residencies, did you see any bias of residencies that were only looking at MDs?
I actually have to say that certainly when I applied to the ER residency, which is what I thought I was going to be doing, I personally felt that pressure because you hear, you're like, oh, maybe, they don't have a lot of DOs in their program. Maybe it's harder to get in. But actually, I ended up they brought me in, they interviewed me. I actually had to call them and tell them. It was really sad, actually. I had to call them and tell them that I needed to withdraw from that because they had interviewed me and they were really pleased. Everything I had done was to get into this one ER residency. And actually, that was the month that I realized I really did not like the change of the shifts, despite the fact that I loved my life when I was there, working in the ER at the time. So, I didn't sense that from them. I think a lot of that was some of the pressure that I put on myself. As far as for family medicine, I applied to an osteopathic residency, so I didn't have to worry about that. I do know that there are some of my colleagues that, that is a valid concern for them because of the sheer numbers, am I going to get in? Are there any biases there? I think, the hope would be that has changed. And certainly with some of the changes that we're seeing with, the merging of accrediting boards and stuff, I think, the hope is that would be less of an issue for some people. I'm not going to really get into that right now because that's a whole other topic on its own.
Yep.
But I didn't feel that for family medicine, if I could just put it that plainly.
Yeah. Okay. Mm-hmm. What opportunities are there to subspecialize as a family medicine doc?
So, you can subspecialize in terms of things like sports medicine. You can choose to subspecialize and do OB. We see a lot of that. You can subspecialize with neuromuscular medicine, which my specialty is family medicine and osteopathic manipulative treatment. So I'm actually subspecialized not just in family medicine, but in osteopathic manipulative OMT. So I have the opportunity to be able to help patients with that sort of therapy when they're here in the office, unlike other individuals that just do family medicine. So those are the ones that I can think of right off the bat. There may be others, but those are the ones I'm aware of right off the bat.
What do the boards look like?
To me, they were essentially just more of the clinical aspects of things that we did compared to, say, step 1 and 2, where it was more of the basic. You saw more basic science with some clinical. With the boards for family medicine, it was definitely much more of an application of the knowledge. So did you have to know the basics? Of course you do. But it was more of, how are we going to formulate a treatment plan for this patient, or understanding what the guidelines are for managing different, common illnesses, be it from a cardiac, pulmonary, GI standpoint, et cetera. So obviously very much across the board. So in the sense that when we took our step 1 and 2, you had to know a lot across the board. Family medicine, your boards are, very similar to that, but it is geared a little bit more towards clinical practice. So that's different.
Do you know what pass rates look like?
Honestly, I don't have statistics on that lately. I would imagine that the pass rate would be pretty decent, but that's just me guessing. So
okay. What do you wish, now that you've been out in practice for several years, what do you wish you knew going into your family medicine residency?
I don't know that you can really know this until you're actually there, but the weight of the responsibility that's on your shoulders when you're the one that is actually in charge of taking care of these patients. So, as a student, you always had a resident or an attending that was, ultimately, signing off on things and making that final decision. When you start residency, that's it. You're the one. I remember on day 3 of my internship year, I actually did the house officer month, which is where you are the resident on call for the hospital. If anyone on any of the floors or the ICU needs something and they need a physician to help out, be it with codes or with orders or a patient's having a hard time, that's the house officer. And so I did that my first month. And, so your first night, you're having to run codes and you have to manage patients in the ICU. And I remember my third day, driving over to to my hospital. And I think it just really kind of hit me. It was like, oh my gosh, I'm really responsible for these people's lives, And I actually remember crying because I was like, oh my gosh, this is for real, And I remember praying, I'm like, okay, God, just please don't let me screw up, And just the weight of that, I feel like that was something I wish I could know before, but I don't think it's possible until you're actually there. I think it's kind of like motherhood, people can prepare you all you want, but until you're there, you don't really know what that means. And so in that regard, I think, the weight of what the expectations are of you is something that I wish I knew more of in terms of preparation for residency. It's a no matter how much anybody tells you, it's a hard, it's going to be hard. It's hard, but it's part of the process. And, I loved it really at the end of the day. I loved every single day. I went home exhausted, but I just loved what I was doing. So that just kind of, made up for all of it really.
What should a student be thinking about or looking into when deciding a residency program to apply to?
So I think they need to consider first and foremost where they want, really the type of training that they want. There are different types of institutions that offer training. Do you want to be in an academic setting? Do you want to be in a community setting? Where do you, what type of environment do you want to, learn in? That's one. And then I think from a location setting standpoint, it's important to kind of think about that. Now, if you're a student, and most students, don't have families. I had I had 2 kids and a husband. So you don't really have to, most people don't have to think about that. But for me, I needed to consider where I wanted to be because I didn't want to have a bunch of shifting of my family. So, I think if you have a family, it's important to consider where you want your family to be. Because if you have to move, you're going to probably be there for a while, and you have to consider, the quality of life that your family's going to have, because you're really not going to be around very much going through your residency. So in that sense, location for someone who doesn't have a family and they're single, they can go anywhere as long as they're getting great training. So that opens things up. But I do think, considering what kind of environment do you want to really learn in, a big hospital, a smaller hospital. I personally wanted to stay locally because, I had a home and my kids were in school. So I stuck to, the surrounding areas that was drivable for me. But I really think quality of training and location of training, I think, are the top two.
What specialties do you work the closest with?
Cardiology, pulmonology, and GI. I think the majority of things that I see on a regular basis involves the needs for those top three specialties. And I think, probably after that would be nephrology, and then neurology. But cardiology, pulm, and GI. I work with those groups constantly.
What do you wish those specialists knew about your job to make your job a little bit easier?
Because I take care of patients who really are limited in terms of their income, I think it's my job to really ensure that they're able to afford their care all the time, all year round. And so when a specialist goes to pick treatment modalities for their patients, the newest and best drug that's out may not necessarily be practical for a patient because they have to be able to afford that medicine all year long. And so I think just really being more mindful of having a conversation with your patients and saying, is this a drug you can afford? Because we see, patients coming to us where they were put on a medicine that they're simply not going to be able to afford. I mean, they're going to be lucky if they can afford it through August, September of that year based on their medical budget, on their budget for their prescription drugs. And I think that's probably my biggest challenge is because I have to coordinate their entire care, it means making sure that it's affordable to them. And so I will often pick up the phone and speak to a specialist that a patient comes in and says, Doctor, no, this medicine is like I had a patient yesterday. Her medication for her psoriatic arthritis was $1,600 a month, and she has like a $4,000 drug benefit. She's going to hit her donut hole with the one drug, by April, if not before. And, those are real issues that we face. And, she's diabetic. She had all these other things going on that she needed medications for. So those are real discussions. So I have to pick up the phone and speak to the specialist and say, hey, what can we do? What else can we try that my patient can afford that can be as effective for her? And we don't always have that option because sometimes the medications that they're put on is really the best thing for them. But I think communicating with a specialist, that's probably something that I wish that they, would be more mindful of because I'm trying to make sure that they can take care of all their other bodies, all their other systems the entire year long. So. But I work with great specialists, and I can always pick up the phone and call them and say, hey, can we talk about this and let me know, is this something that we have some other alternatives for, or is this something the patient absolutely needs? And what are our options? Can you provide more samples? Whatever it is we need to do to try to help the patient out if they really do need to be on those expensive meds.
Are there any special opportunities outside of clinical medicine for family practice?
Absolutely. It really depends on the individual and what their interests are. I know that I've been approached on many occasions to be a medical director for, different facilities. I've been talked to about doing reviewing charts to earn extra income. I really feel like as a family medicine physician, I have the ability to gear my practice in ways that I can diversify how I want to serve my patients and make it my own, if you will. So there are business opportunities that they can pursue, but it really depends on what their interests are. Here you are, Ryan, doing this, great service to medical students. It's an opportunity for you to serve in a different way outside of your field. And so I think for family medicine, it's very much, wide open field for students or for people that go into that field, because you're able to diversify, as much as you want, really. There's a lot of ways to serve, be it politically. I'm very involved in my profession. I'm the president of our, county organization here. I'm involved, locally, nationally. I'm able to, be an entrepreneur in things, not just in the running of my practice. I have a PhD in molecular immunology with cannabinoid research. So that's something that is allowing me to have some diversification in terms of opportunities for myself to educate, be it physicians or the community. So really it depends on what an individual wants to do, how driven they are to go after it. But I love that with family medicine, there's such a diverse knowledge base that you can pick the areas that you want to make it work for you in ways outside of the clinic walls, really.
What do you like the most about being a family practice doc?
I love my patients. I love that I get to really know my patients and know their families. I have 3 generations of families that that I see. Because of family medicine, I can see kids, I can see, young adults, all the way up to patients in their 80s and early 90s. And I love that I get to have these types of relationships with my patients where I really feel like they've entrusted me with their care. And once, because I've earned that trust, they will tend to be more compliant in their response to what's needed for them to stay healthy. But I also love just the fact that, we can laugh and I can be silly with them. They know me so well. They know that Dr. No, she's hilarious, and they know all the faces that I make. It really is a family medicine. I love it. I've had the opportunity to have, monthly birthday celebrations with my patients, where we just get together, have cake and snacks and just hang out for, an hour once a month. And, I get to do those types of things with my patients to get to know them outside of the, outside of their, the room, where we're having deep conversations. We get to have a once a year Thanksgiving dinner that we do for all of our patients and, celebrate just a time of gratitude. And I love that I get to do things like that. And I think family medicine has really allowed me to build great relationships with my patients. I live in a small community. So, I like that. I like that, I get to just have great relationships with them.
What do you like least about it?
What do I like least about it? The day when you have like a full schedule and you've got the patient that keeps going, oh, and I have this, and I have this, and I have this, you feel the pressure of, oh my gosh, I really want to take care of those needs, but I can't because I have, other patients that I want to stay on top of. And not, let my schedule run crazy, late and behind. And I think that's my least favorite part of things is just really not being able to take care of as much things as I can when they're here. I think some of that too is dictated. A lot of that actually is dictated by patients' insurance, I can take care of all of this, but I'm not going to get paid for it, As primary care, we want to take care of as much as we can while they're there, but sometimes we have to make them come back, and that's really frustrating in those scenarios where I do have the time, but I know that I'm not going to get reimbursed necessarily for what I'm doing if I do that. So if that's twofold. It's the inability to really take care of everything while they're here because I have to keep moving on to, keep my schedule moving, as well as a lot of the bureaucracy that it takes to really get the care for my patients that they need. I think those are the two biggest frustrations for me.
If you had to do it all over again, would you?
Absolutely. Absolutely. I walk into my clinic some days still, even 5 years down the road, 5 years out. And sometimes I sit in my office and I was like, wow, I can't believe I get to do this. I love that I can just sit in my office and, revel in the fact that I've been so blessed to build my practice, to take care of my patients, and to just kind of do it my way as much as possible, I would absolutely do it all over again. It's not been an easy road, but, a lot of times things that are worthwhile usually aren't. So I really am grateful that I get to do what I do. So it's not always a bed of roses. There's a lot of frustrations that you can have, but that comes with any job. It doesn't matter what job you have. There are challenges. But that question of would I do it again? Absolutely, in a heartbeat.
Do you see any major changes coming to family practice, whether it be technology or medications or just the way it's practiced?
Well, I think that there are major changes that have been happening with family medicine for the last, 10 years. And I think those changes are going to continue to be perpetuated. And what I mean by that is, as a family medicine doc, you're really that quarterback for the patient, trying to coordinate all their care, be it, specialist care, ancillary care, be it, PT, OT, whatever, skilled nursing, home health care. You're really coordinating a lot of the patient's care. Now, what we see with the way healthcare is really moving in this country is that that's really the way that we can work towards, helping to ensure that the patient gets what they need, and also that they can, that coordination of care is happening in a way that's not, that there's not a bunch of disconnect, really as, there's more communication or an attempt to achieve more communication between physicians and institutions like hospitals to be able to ensure that there's greater coordination of care and not a bunch of waste, but just really having someone who's on top of what's really going on with a patient. I think the stress for that type of healthcare has been more of the focus and is where, we as a country is moving more towards. So I think that, we're going to be seeing a lot more of that. I think that so much of, the value-based care that they're, that is being, said and touted is, really being coordinated by primary care, which is huge. And that's been the way that I was taught to practice in residency, to really take on that role and do the best thing for the patient. And so I'm really grateful that was the focus of my training. So I'm not having to, figure out how to make the dots connect. But I think that individuals that are going into primary care, there's going to be more of a requirement for you to actively really manage that patient's overall care. And you really got to want to do that in order to do a great job by your patients. So I see that really shifting.
Any last words of wisdom for the pre-med or medical student out there thinking about family medicine?
When I was going through my rotations as a medical student, I had a lot of people tell me a lot of things about different specialties. And there were a lot of people saying, I think you should do this because, you should do allergy and immunology because you have a PhD in, immunology, or you should do infectious diseases because of your microbiology background, or you should do this or that. Oh no, family medicine, don't do family medicine. You're not smart. You're too smart to do family medicine. I had people tell me that. And, there were a lot of people giving me a lot of input about what they thought I should or shouldn't be doing. And at the end of the day, I really had to stop and block out all of those, all of those voices and say, Sasha, what do you want? What do you want that you think will make you happy? Not what other people want of you or what other people expect. Where are you going to be most happy practicing medicine and helping people? Where do you see yourself in 10 years still really engaged in patient care, 10, 20, 30 years down the road? What is that for you? And I would say to them, at the end of the day, you have to make the decision that's best for you and your family. Just try. I mean, obviously, we want to get the advice from our mentors and our preceptors when we go through our rotations. But at the end of the day, you really have to feel great about what you're going to be doing. So, take some quiet time and do some soul searching and figure that out for yourself. Because if you're true to yourself, you're going to be happy and you're going to, be doing this profession for a long time.
All right, that was Dr. No, and she, again, is a solo private practice family medicine physician, and she just shared her thoughts on what you should be doing if you are interested in pursuing family medicine. Great specialty, a very much needed specialty. I think primary care is where we need to go as a country to help improve our outcomes here in the U.S. Our outcomes are pitifully low compared to most other industrialized countries that have great health insurance, health care. Ours is lacking. So I hope you take a look at family medicine and seriously give it a thought. If you want to interact with Dr. No more, go follow her on social media at Dr. Sasha No. That's DrSashanoe. I hope you learned a ton today, and I hope you join us next week here at the Specialty Stories and MedEd Media.